So I'd like to welcome you to another one of our series of The Power of Pivoting, Managing Through Crisis. I am C. Ronald McKenzie, MD, an internist at the Hospital for Special Surgery, the Professor of Clinical Medicine and Medical Ethics at Weill Cornell Medicine, and I have served as the moderator for this series. So today we have another session pertaining to the educational efforts at the Hospital for Special Surgery. We have Dr. Duretti Fufa here today, who's an associate professor of orthopedics at Weill Cornell and is the director of the Residency education program at Special Surgery. A very important position here. You've heard previously in our discussions with Dr. Bostrom and Laura Robbins concerning matters pertaining to resident education. We thought Dr. Fufa would be an excellent person to expand on that subject. So good morning, Rudy, how are you? So maybe you could just tell us a little bit about the efforts of the, as the residency director here over the last 6 weeks in this setting.
Obviously unique. New York has been very uniquely positioned at the epicenter of this crisis, and as a result, our residency, among all the others really in the city, were challenged quickly by having to rapidly respond to the growing clinical needs of the hospital systems around us and the unprecedented burdens that the clinical care put on. Even though our topic and my role as a residency program director has to do with resident education, one of the important factors I think to consider is that even though residents are really frontline workers with regards to patient care, they have a unique position not only as healthcare providers but as trainees and still as people who are gaining education here. And so I think that was one of the principles that we really needed to balance, the balance between the care that we need to provide for the patients, but also preserving resident education to some degree, and importantly, very importantly, resident safety and health.
So can you tell us a little bit about the response of, I'm interested in both the faculty's response and the residents' response, because from my previous conversation I understand the residents really did step up quite impressively with respect to the maintenance of their education, so they're very concerned about that. How about the faculty? We
thankfully already had a very well-functioning residency leadership group composed of about 6 members of orthopedic faculty who are very committed to resident education. Myself and Dr. Green, the associate program director, really relied on this whole team to help us as we structured the reorganization alongside the residents and in parallel to the organization of the faculty that we already had leading the residency. We, with the guidance and at the suggestion of the residents, created a very parallel system of resident leadership to help us in terms of organizing ourselves, maintaining as best as we could, principles of education, balancing those with the service that we wanted to provide, and importantly, that allowing those residents to serve as representatives for their classmates or co-residents.
So, having been here, almost 40 years, I'm well aware of how robust the educational effort is on the part of the orthopedic staff. It's really quite extraordinary. So, for instance, the morning rounds that are really basically part and parcel of the experience here, can you maintain them for instance, by methodologies, video methodologies, Zoom, and so on?
All of our traditional morning sign-out rounds for our patient censuses have been converted to sign-outs of some form. They can be transmitted by telephone, sometimes by video conferencing, but I think that mode of communication has been able to be preserved quite well. In addition to that, some of the transitions that we had already made by way of an electronic medical record being a single place for all of the patient information to be housed, and handoff lists continue to be very important in terms of communication. for patient care, particularly in this time in which we are rapidly having manpower changes, as sometimes health or periods of quarantine would disrupt the clinical care providers who were expected to participate in care. Along those lines, using digital, remote, and sort of live modifiable means of identifying where residents are at certain times by way of sort of shared documents that are housed on the internet really allowed all of us, both on the faculty side as well as on the resident side, to be able to quickly identify who was where when the pieces were moving relatively rapidly as we approached the surge.
So how did you feel as a faculty member about your ability to actually supervise the activities of the residents?
In some ways, during this period, because I think one of the very important guiding principles that our hospital has utilized all the way from the leadership of the hospital and parallel in our leadership of the residency has been frequent and transparent communication. And so our mode in the residency of doing that was with group calls 3 times a week at the beginning of the crisis. And so in some ways, the communication and my ability to know what is going on at all the clinical sites where we're providing care, in fact, might have been enhanced given the frequency of the communication. The structure of our calls was very organized, in which the chief resident of each of the clinical sites would present the interval days, patient census, number of consults, where they had to go for consults, whether that was the ER, which are higher exposure types of areas in terms of risk for COVID exposure, how many inpatient consults there were, and then very importantly, communication of things that were not previously a part of traditional sign-out, including things like what is the appropriateness of PPE, what are the hospital policies at the different clinical sites where we're delivering care, as all of us were negotiating and rapidly trying to develop best practices. So that level of communication was incredibly helpful after understanding what was going on at all of the sites where we're delivering clinical care as a residency. I was able to, in a very direct way, communicate that with the hospital leadership so that we could try to bring as much consistency and responsiveness as we could to what was a very rapidly changing environment.
And are you getting much direction from the GME concerning the maintenance of educational efforts here in this situation? I mean, we are in a somewhat unique environment. I mean, there are a few other hot spots in the country where orthopedic training would be taking place, but this must be the most stressed of them all.
It is, and in New York City, all of the residency programs did file for what's called Stage 3 pandemic status based on the GME criteria. We, at the very beginning of the crisis, were in Stage 2, in which the basic tenets of accreditation were all maintained and always were: preservation of work hour restrictions, appropriateness of supervision of any of the activities that residents are doing. But the change that happened as the burden of COVID care became greater was to transition to Stage 3 for us and for many programs, as I mentioned, in the city. And that involved the ability to put on pause the academic programming for the residents. And that is simply because of the need to prioritize patient care during that period of time. I think we're very fortunate that when we were in Stage 2, we had already enacted so many initiatives to convert our educational platform to remote learning, and as a result, residents who were able to, while they were on periods of quarantine, were able to continue, even in Stage 3, accessing a lot of digital education, in spite of the fact that none of it was required at that point, given our Stage 3 status.
So, you know, we're obviously still relatively early in this process, but do you think that this is going to change how you might approach residency education going forward?
It absolutely will, and I think in spite of what a challenging period this has been and continues to be the changes in remote learning, digital offerings of education, as well as some of our forms of communication, I think will have been strengthened as a result of this. Some of these initiatives are ones that we've been planning for. How do we improve our communication between clinical sites? How do we share educational material that's taking place on one campus with other campuses? We've been, in some respects, forced to really accelerate those efforts, and I'm certain that many of those will not revert back to the pre-crisis status, but rather be incorporated as part of our education.
So you found them to be really, as the director, a pretty effective means. Are you surprised at how effective they are?
We're getting very good feedback from the residents. Certainly, remote learning and remote education is not going to entirely replace education, but I think that we've realized there are components of it that are likely better to be transmitted in a more self-directed way. Prior to the crisis, we had already enacted a flipped classroom model in which we try to make our in-person lectures much more interactive and do more of the didactic in a self-directed learning kind of a format. And this is just another step in that direction of utilizing the time that we will in the future be able to spend in a face-to-face setting, utilizing that for the highest yield of interactions with patients, discussion of cases, demonstration of physical exam or surgical techniques, things that really can't be entirely replaced by remote learning.
Okay. So, I'm also a bit interested in your response to these important young people to us with respect to the health implications of the environment that they're working in. And I'm referencing here both emotional consequences, which could be longer term, frankly, or more immediate threats to their health.
The residents are really uniquely positioned, as I mentioned. They are right at the front line. They are, in many respects, a vulnerable population, given that they are, as I mentioned, really frontline workers. And so I think all of us in leadership of resident education understand that their health and safety is really our number one priority while we are maintaining patient care. The reality is that in interacting with patients in this environment currently, providers are being exposed to COVID. As a result of knowing that, we very quickly organized the structure such that there was, as I mentioned, transparency about where everybody was in terms of clinical rotations, providing of care, and utilize the resident input as well as taking into account personal considerations for each resident, how we distribute or resident manpower with regards to the risk of exposure, since not all sites have the same risk of exposure. That was really where I think our resident representative group came into play very substantially in allowing us to, I hope that the residents have found it to be so, allocate our clinical care to the sites that needed clinical care, have needed clinical care the most, while maintaining equity in terms of exposure amongst the residents and fellows as well as the faculty members, but also taking into account any personal matters with regards to home life, personal health risk factors that may exist, so that we can really be, amidst what is a very challenging situation, provide everybody with as much, hopefully, security as could be expected in this situation.
And on the emotional side, I mean, they're really very robust, capable young people. But are there concerns about any longer-term implications of this experience?
Absolutely. I think in general, in the healthcare system, we are just beginning to start to identify and understand what those may be. I think our hospital did respond early on by bringing in a crisis management specialist to help us, and certainly in the leadership of the residency side, we very quickly leaned on him for advice about what is our style of communication with the residents? Are we communicating frequently enough? Are we not communicating frequently enough? When do we know that we need to refer to sort of a higher level of help? And how do we encourage residents to discuss these things? Not only was the crisis management specialist helpful, but also obtaining peer counseling training, which both myself as well as some of our residents were able to go through in order to be resources for each other. And I think that the frequent communication also has been very important. The more we communicate, the more we share the experiences that we're having on the front lines, taking care of patients, the more we might be able to support each other. So absolutely, I think that these are considerations. I think we've done the best we can to negotiate those as well going through this. Our residents are very already we had a very wonderful culture within our residents to support each other, and this crisis has really just highlighted how supportive they are of each other, and allowed us as the residency leadership to try to help foster that. So given how challenging this situation has been, I think that one of the factors that hopefully has helped our residents with regards to well-being is all of us, everybody in our country is facing challenges of uncertainty, of feeling out of control of our environment, of what may be coming in the coming days and weeks. And one of the benefits of utilizing the resident representative group, being responsive to and frequently communicating with them, was the ability to preserve, to the best degree possible, some autonomy for the residents in terms of where they would be, where clinical care was needed, where safety could be improved, and being responsive to that. And so I think that to the degree we are able to provide them with the ability to make decisions for themselves and have some autonomy in their coming rotations was very beneficial also.
Well, good. Well, thanks very much, Dr. Fufa. We appreciate your comments. I think they resonate very well with the comments and discussion I had earlier with Dr. Bostrom and Ms. Robbins. Thank you.